So we're going to be talking about hepatitic and cholestatic pictures, problems with your liver itself and problems with your biliary tree. These are going to be lumped together because essentially it doesn't matter where the damage occurs, whether the damage primarily is from the liver substance itself or whether it's from the biliary tree. Both of it will cause impairment of the way that the liver works. Over a long enough period of time, they will all result in cirrhosis of the liver, which is the final common pathway of liver damage. Once you get liver damage, it fails to perform its synthetic function of making the things that it needs to. It fails to get rid of and metabolize those things in your body that your body wants to get rid of. The most marked when it comes to physically examining people are vasoactive intermediates, those chemicals within your body that your liver usually eats up, but if it doesn't, will circulate around the body and cause blood vessels to dilate. We notice that with spider nevi. Notice it with the blood vessels that dilate around the abdomen. We can also see those chemicals that are testosterone, estrogen. Estrogen predominantly isn't metabolized by the liver because the liver isn't functioning properly, and in men cause loss of virilization, loss of pubic hair, loss of axillary hair, smoothness of the skin, slightly greasier appearance, hair loss. So the final common pathway with any of the things that damage the liver or the biliary tree result in failure of synthetic function and a classic appearance of somebody with decompensated liver disease, including portal hypertension and ascites. Portal hypertension, if it's high enough, also results in esophageal varices. So we're going to talk through the subject, and this is all going to be focused around using the take-home points to start points of discussion. A hepatitic picture is caused by damage to the liver cells. That causes a rise in the ALT and the rise in your AST. ALT, I think of the L in ALT as standing for liver, very specific for liver. AST, S in my mind, selection of other things, can also be raised if you get damage to muscles, hemolysis, and a variety of other different things. So ALT is much more specific to liver. The cholestatic picture is caused by blockage or damage to the bile ducts. And for that, you get a rise in your ALP and your gamma-GT. Now, again, some reason circulated around that gamma-GT rarely is a marker of whether somebody's an alcoholic or not. And actually, it's a very poor marker of whether somebody's an alcoholic or not, and we'll come back to the reasons behind that. I use gamma-GT much the same way as, well, in years gone by, much the same way as you probably use ALP isoenzymes. As you get an ALP rises, an ALP can go up because of damage to the biliary tree, but also if you get damage to the bone, it can go up if you've got a placenta that's present, so in pregnancy, and also in certain seminomas and testicular tumors and elsewhere. Now, instead of just automatically asking for an ALP isoenzyme to work out whether it's bone or liver, you could just as easily ask for a gamma-GT, and if the gamma-GT is raised along with a raised ALP, you'll be fairly sure that the ALP is of a biliary tree cause and not from an alternate cause. Bone isoenzymes are quite expensive, so that's the reason that I would use that first in order to make that decision. In reality, you know it's never as simple as that. You don't get AST and ALT sky high and an ALP that's entirely normal. Or vice versa, an ALP that's sky high and an AST and an ALT that are entirely normal. So really, your job, the liver is all one functioning unit. There's lots of tiny little small biliary ducts within the liver itself, and there is an overlap of things that damage your liver, may give you a slight ALP rise as well. But what you do is you use the magnitude of the rise of either the hepatitic enzymes compared to the rise in the biliary tree enzymes in order to allow you to make the decision. So, for example, if you've got an ALT, which the normal range is probably about less than 35, let's say. And ALP, depending on which hospital in, usually less than 110. If I had an ALP of 190 and an ALT of 130, although this number is bigger, this has only gone up by about 60% increase. Whereas if I look at this, this is almost a 400% increase, just very vague maths. I look at the size of these rises, and then I say whether this is likely to be a hepatitic cause or a cholestatic. And since this percentage rise is much greater, this is most likely to represent a hepatitic pathology, not a cholestatic pathology. Does that make sense? It's never purely divided into one rise and another. Point number 3, liver dysfunction from the above over a long enough period, either hepatitic damage or cholestatic damage, results in an inability of the liver to perform its function. And that causes a rise in bilirubin, so high bilirubin, low albumin, and also a lack of coagulation factors, so the INR goes up. Now it happens in that order. Bilirubin tends to start drifting up first before albumin starts to come down, which happens before INR starts to go up. So by the time you get to the stage of INR going up, you know you're well along that path of badness. Bilirubin, the fact that bilirubin starts to go up first is something that we use when it comes to looking at poor prognostic features for primary biliary cirrhosis. And we'll come back to this in a little while. If you start to notice the bilirubin's going up, actually, it's now getting to the stage where the liver is struggling to perform its synthetic function. And it's only a matter of time before albumin drops and then INR goes up. Just bear in mind that you can also get bilirubin going up, albumin coming down, and INR going up with somebody with severe sepsis and starting to develop a process of diffuse intravascular coagulation. So that's slightly different. That's acute liver dysfunction and coagulopathy, slightly different to a liver that's become more and more fibrotic with time. Does that make sense? Portal hypertension from any cause results in ascites and eventually varices. Now, when we were talking about before, anything that caused an increase in portal blood pressure, whether that would be a portal vein thrombosis, liver cirrhosis from any cause, and we'll talk about all of the causes later, a hepatic vein thrombosis, high venous pressures from problems with the heart, and you may have even seen people with ascites, I'm sure you've seen people with ascites, with severe cardiomyopathy or severe ischemic heart disease and a poorly functioning left and right ventricle. And you end up with ascites. If you've got ascites, that means that your portal pressure is high, because the pressure is so high that fluid is leaking out. The oncotic pressure pushes fluid out faster than those capillaries or lymphatic system can mop it up. If you've got high pressure in your portal system, your esophageal venous system drains into that portal system, as does your gut. And if the pressure is high, the veins in your esophagus start to dilate, and those are esophageal varices. So esophageal varices, ascites, those all occur when you get problems with your liver and problems with an increased portal system from any cause. And if the liver can't perform its function, you'll eventually get a raised bilirubin, a low albumin, a high INR, and all of the things that you're used to seeing with vasoactive mediators not being metabolized and estrogens not being metabolized, hair loss. One thing I'd just like to bring up here is finger clubbing. Now, finger clubbing, the mechanism that this occurs. Platelets become activated when they're going through the body. And whether they become activated when they come across a nasty or whether they knock into something. Platelets, when they're activated, release platelet-derived growth factor, and that causes tissue to proliferate. When platelets circulate around your body, some of them become activated when they come into contact with things, and they make it to their lungs. The lungs is a metabolic workhorse that does a lot more than just exchange oxygen. And it ends up turning off these platelets and stopping them from being activated so that they no longer release platelet-derived growth factor. If there is a communication so that platelets can bypass the metabolic workhorse of the body, the lungs, and can go straight from the venous circulation into the peripheral circulation, those platelets are still activated, releasing platelet-derived growth factor. Those then get washed down blood vessels and eventually get stuck on tiny little capillaries where they carry on releasing their platelet-derived growth factor and clubbing occurs. In cyanotic congenital heart disease, the pathway that occurs that allows blood to go from the venous circulation direct into the arterial is clear. You've got a VSD that is returned. You've got abnormal position of blood vessels. You've got ASDs. Blood can pass directly from the right side of the heart to the left side of the heart. So that's how those platelets make it through into your peripheral circulation, get stuck in the little capillaries around the nail bed, releasing their platelet-derived growth factor, causing clubbing. But liver cirrhosis, those vasoactive metabolites that are circulating around the body, not only cause telangiectasia to occur, but they also dilate blood vessels within the thorax itself, allowing small microshunts to occur and activated platelets to make it all the way through into the systemic circulation and cause clubbing. So that's how clubbing occurs. The treatment algorithm for chronic varices is very different than that for acute bleeding varices. Very difficult thing to get your head around when you're doing a gastroenterology job is somebody comes in for an OGD for whatever reason. It might just even be for a little bit of dyspepsia. You do an OGD and they've got varices that are so big they're occluding the esophagus. And you think, oh, this is bad news. They ought to ban those. You don't touch them. Unless varices have bled, you leave varices entirely alone, even if they're entirely occluding the esophagus. And in your mind you think, this is awful, and all you need is a sharp piece of toast to come by there, but you leave them entirely alone. If you find varices coincidentally, the only treatment that you give somebody is propranolol. That's all you give somebody, propranolol. That seems to decrease pressure within those blood vessels and decrease the likelihood of them bleeding by a significant amount. The only reason that you ban some varices that have never bled is if somebody cannot tolerate propranolol therapy for whatever reason, and then you would ban them, prophylactically ban them. Acute bleeding varices, so now you've got somebody, I don't know how many of you have seen a proper variceal bleed. It is horrific. You're in resus, there is blood on the walls, there's blood on the floor, there's blood covering you, there is blood everywhere. The nasty, horrible things, and you've got to get on things quickly, ordering blood, making sure that the person is fluid resuscitated. But essentially, other than all of that ABC and replacing your blood products, it circulates, therapy circulates round terlipressin. So these are the British Society of Gastroenterology guidelines. Terlipressin, fluid resuscitation, stabilize your patient, and then get them down to endoscopy as quickly as you can. Ideally, tubed and ventilated, but whatever happens, happens. Terlipressin, 2 milligrams TDS. Get the person down to endoscopy, and then the process of trying to band as many of those varices as possible. Once you've banned and stabilized the patient, you send the patient back to the ward, and then you keep on bringing them back at regular intervals to ban their varices again and again and again until you can see no more varices. So you ban them all away. So you bring them back again to endoscopy, then at 3 months, then at 6 months, then at 12 months, and you keep on bringing them back again and again. And banding is as simple as they pop a little tube over the varices, they suck it into the tube, they roll an elastic band over the varices, the band constricts, causes that to become ischemic, that falls off, it's clotted behind it, then the elastic band pops off when the varice falls off, and then you poop out the elastic band later. So that's banding. Sclerotherapy we don't really bother with anymore. It's all banding. If banding is successful, you keep on bringing them back, keep on banding them, and you prescribe propranolol as well. Not the same time when their blood pressure is low and you're giving them terlipressin. This is once you've controlled it with banding, then you add in propranolol. The next step, let's say you take them to endoscopy and you try and band them, and you failed your banding, your first primary banding event. The guidelines and what you'll be examined on say, what you do now is you put in a Sennstein-Blakemore tube. So you've got this tube, you feed it down under endoscopic guidance. You take it down, you blow the balloon up on the end of it. There's an esophageal balloon which is not really used a lot because most of the varices tend to occur, this is your stomach, most of the varices occur here. You blow up the balloon here, and then the tube comes out of their mouth and you hang sandbags or bags of saline on the end of it to pull this balloon up and wedge those varices and stop them from bleeding. It's a Sennstein-Blakemore tube. Almost all of the time now, people are taken intubated with Sennstein-Blakemore tubes. Again, when I was a house officer, we very frequently would have people on your standard gastroenterology ward, awake, with blood oozing up and a band coming out and sandbags hanging over the end of the bed. And the philosophy was kind of, you're an alcoholic, you've got variceal bleed, deal with the fact that you're now bleeding. This is a nastiness, part of the therapy that might allow you to stop. It's not really accepted so much anymore. People are ventilated partly to stop them from inhaling the blood products. So if banding has failed on one occasion, Sennstein-Blakemore tube, and then you move directly on to doing a TIPS. And the idea of the TIPS is you've got a liver, you've got your portal system, and now this is your spleen. The pressure in this has become very, very high. You feed a catheter down, and the idea of the procedure is to insert a shunt to allow blood to directly pass through the shunt and bypass the fibrotic liver, and that drops the pressure down instantaneously. And TIPS in itself as a procedure is very effective at doing that, although if you can think that your liver was metabolizing all of these nasty things that were coming from the stuff that you're eating in the gut and all of these pathogens, and it does invariably induce encephalopathy when you do it, but most of those people get better and back to functioning. If you're encephalopathic before you even had your TIPS, then that's almost a contraindication to even bothering trying. So you try banding once. If banding fails, and you move directly to Sennstein-Blakemore tube and TIPS. In reality, what we do is we give it a go. We give it a go, and banding fails. So we put the Sennstein-Blakemore tube in, send them to ITU overnight, resuscitate them, settle everything down, then take them back to theatre and do endoscopy again in theatre and give banding another go. So that's sometimes where experience can work against you in the exam, and they say, which one of these things would you do? Because the guideline is, if you fail banding once, you take the person straight for Sennstein-Blakemore tube and a TIPS, but that's not what we do, really. Because the thought is, TIPS is not without its risks. TIPS, you can have all sorts of problems with TIPS, and if you're sticking a Sennstein-Blakemore tube down in the stable by the morning, why not give it another go? But that's not the guidelines. So now is a transjugular, can anybody remember portosystemic shunt, so there's two S's, isn't there, rather than two P's. Transjugular intrahepatic portosystemic shunt. You guys know better than I do. No, that's left in forever. And if you think about it, it's a little tube. What's going to happen? They can become infected, they can become thrombosed. And so what you don't too infrequently see is then sudden relapse of people. They get a clot in it. Their pressures go up again and they can bleed again. If you've had a variceal bleed, the likelihood is that, and you band it and everything settles down, there's a 50% likelihood that you're going to have another catastrophic bleed from those varices. There's a 50% chance that you're going to bleed to death or you're going to die in that next admission. So variceal hemorrhage straight away, you're talking 50% mortality straight at the front door. Then even if you patch up everything and everybody's fine, you go away, there's a 50% likelihood that you're going to end up very soon in with exactly the same thing and a 50% chance that you're going to die each time that that occurs. So prognosis, by the time it gets to that stage, it's not pretty. Only previous infection with hepatitis B gives you hepatitis B core antibodies. Again, they still like these questions of interpreting hepatitis B serology. It is very straightforward, and we're going to go through it quickly. Even though you know it in the exam, keep on checking whether what they're talking about is they're talking about an antigen or an antibody. Because you'll see something that you recognize and ignore whether it's an antibody or an antigen, and that makes a big difference. Makes a big difference. So the first we're going to talk about is hepatitis B surface antibodies. Hepatitis B surface antibodies. Everybody in this room should have hepatitis B surface antibodies. This shows that you have an immunity to the antigen, hepatitis B surface antigen, the antigen that's on the surface of the hepatitis B virus. It's a DNA virus, hepatitis B. All of the rest of the hepatitis viruses are RNA viruses. It's a nice question that comes up again not too infrequently. Which one of these is a DNA virus? Hepatitis B is the only one. Now, if you had a patient walking off the street and you took blood tests from them and you found out that they had hepatitis B surface antibodies, there is no way for you to tell right now, just from that, is have they been inoculated for hepatitis B, or have they just had hepatitis B in the past and seroconverted? So they've had hepatitis B, but their body has cured themselves of it. As far as seroconversion rates, if you've got hepatitis B as an infection, 80% chance that you're going to cure yourself of your hepatitis B if you catch hepatitis B. If you've got hepatitis C, there's an 80% chance that you'll never cure yourself, that you're going to be a chronic hepatitis C carrier. So it's the other way around, only 20% chance in hepatitis C. So you can't tell just from hepatitis B surface antibodies whether you've been inoculated or you've just had hepatitis B before, seroconverted, and now you've cured yourself. The way that you tell is you look for hepatitis B core antibodies. The only way that you can get hepatitis B core antibodies is if you've been infected before. So none of you should have hepatitis B core antibodies. There is no such test that allows you to look for hepatitis B core antigens. There's no blood test that allows you to do that, but that's within the liver itself. So you can't look for, in blood tests, hepatitis B core antigens. You can only find hepatitis B core antibodies in your blood test. You can see hepatitis B surface antigens. Antigens means the baddie. So if I did a blood test today and I said I've got hepatitis B surface antigens in my bloodstream, what does that mean? I'm infected right now. How do we define chronic hepatitis B? And it is so arbitrary. It's defined by hepatitis B surface antigens for greater than 6 months. So you do one test, you find that they've got hepatitis B surface antigens. You do a test 6 months later. If they've got it 6 months later, then we call that chronic hepatitis B. The likelihood of them seroconverting is much lower because it's already been there for 6 months and your body hasn't done anything about it yet. Hepatitis B E antigen. E talks about the envelope, and E, it would be lovely if this was I, infectivity. Infectivity. If you've got hepatitis B E envelope antigens, you're highly infectious. And that is an indication to treat somebody with pegylated interferon B. Pegylated interferon. Now, hepatitis B virus, as a virus, has got sneaky, it's got smart. It's worked out that if we express hepatitis B envelope antigens, then somebody's going to come along and batter us with pegylated interferon. So what we've worked out is, let's not express that. We'll still replicate, and we'll have high viral load, and be highly infectious, but we'll go under the radar, we'll go sneaky. And those viruses that worked out how to do that are called pre-core mutants. So we no longer use, we did when I was an SHO, use hepatitis B E antigen, envelope antigen, as our indicator, and that's now changed. We go directly to the source. We count the viruses. And if the viruses are greater than a certain level, we now have criteria for treatment with pegylated interferon that has, if your viral load is greater than 10 to the 5, then you treat it. You're going to be highly infectious. These viruses are crawling everywhere. If your ALP is increased on one occasion, so if you do one blood test and find out that your ALP is up, then we treat you. Or if we do a biopsy and find fibrosis on liver biopsy, we have to treat you. We've got to stop that liver from becoming cirrhotic. Otherwise, you'll be in and out. You'll need OGDs and ultrasound scans of your liver, monitoring in a hepatology clinic. You might have an esophageal bleed, and that's all going to be very expensive for us. So this is our treatment for pegylated interferon. Okay. Disha. If I had presence of hepatitis B surface antibodies for greater than 6 months, what would that mean?
Surface antibodies greater than 6 months, but you can't tell. Well, that would mean that you're immune to it.
Mean that my inoculation is still working, and that's the classic type of trick that they'll try and drag you in. You'll see the hepatitis B surface, you'll see the greater than 6 months, you'll want to go, your brain is telling you, oh, you've got chronic hepatitis C. No, it just means that you've been hepatitis B surface antibody positive for greater than 6 months. So they're going to try and suck you in with an antibody and antigen thing, because it is so simple that that's all you need to know. There's some other bits and bobs, but if you focus in on these, you'll be able to work out everything that you need to know from antibodies, hepatitis B surface antibodies, hepatitis B surface antigen, and hepatitis core antibodies. You'll be able to work out all of the answers just from those two, and knowing that pre-core mutants now mean that we do a viral load. But if you did find somebody with hepatitis B envelope antigens, then that would mean that they're highly infectious. What about if you find somebody comes along, they've got a history with EVA, they've got a history of hepatitis B in the past. You do a blood test and you find out that they've got hepatitis B surface antibodies, but the blood test also suggests that they've got hepatitis B envelope antibodies as well. Should you treat them?
No, they might be immune.
They're immune, and they've got antibodies towards that envelope antigen that used to be there. So they were highly infectious at one point. They've now got antibodies, but it mentions nothing about hepatitis B envelope antigens. So again, it feels as though I'm laboring the point, but trust me, it's such an easy trap to fall into. Okay, only current infection gives you hepatitis B surface antigens. If over 6 months, that equals chronic hepatitis B, but it requires treatment only if you fulfill one of those 3 criteria. Viral load greater than 10 to the 5, ALP raised on 1 occasion, fibrosis on liver biopsy, and it's in the box on the back. Primary biliary cirrhosis is a disease of the M's. That's why I've kind of highlighted that M. Middle-aged woman, usually, AMA-M2 antibodies. An IgM level is raised, and you would see that IgM raised on plasma electrophoresis, the same way that you would look for low IgA levels in celiac disease, or the way that you would look for a monoclonal band as part of the Bence-Jones proteins, and also the lytic lesions and the plasma cells greater than 10% for multiple myeloma. Took me a little while to work out when I think back to when I was an SHO that maybe I'm just exposing my lack of listening when I was at medical school. That primary biliary cirrhosis is a disease of these really tiny little blood vessels, microscopic tiny little things. Primary sclerosing cholangitis is the disease of the big bile ducts that are down here. Primary sclerosing cholangitis used to be diagnosed with ERCP, endoscopic retrograde cholangiopancreatography, where you inject a dye up here and you're looking to see for tightnesses and dilatations to make a diagnosis of primary sclerosing cholangitis. Now, the only time you ever do an ERCP is if the person is going to require intervention with that. If you're going to take a biopsy, if you're going to pull back a stone, if you're going to do some luminal ultrasound, if you're going to try and dilate, do a sphincterotomy, you only do an ERCP if you're going to intervene. Otherwise, if it's just a diagnostic procedure, you always do an MRCP. So it's an MRI scan, and you can get the same information. The primary biliary cirrhosis, these are such tiny, microscopic little biliary ducts that the dye can't get high enough in those, the resolution isn't high enough to be able to see whether somebody's got primary biliary cirrhosis. The only way definitively that you can tell is by taking a biopsy of the liver and looking for onion skin fibrosis around those bile ducts. That's very difficult to do. So we make the diagnosis on the clinical history and ideally using the autoantibodies. So AMA-M2 are what we would look for to help make our diagnosis of primary biliary cirrhosis. What autoantibody, if we did it and the test came up back, somebody had raised ALP, slightly raised ALT, and we did the test looking for autoantibodies and we found P anchor, what's going to be our diagnosis, Ram? Going to be? PSC, primary sclerosing cholangitis, because that's associated with inversely proportional to the severity of ulcerative colitis, and that not infrequently. About 50% of cases were P anchor positive. If we found AMA-M2, we're home. We've made our diagnosis. We won't bother taking a liver biopsy. There's still people not too infrequently have complications from it. And there are many documented cases of people dying from liver biopsies, bleeding very, very heavily. The signs of chronic liver disease are the same no matter what the underlying cause. And we're going to flip over to the reverse side of the page and start talking about what some of those causes are. Autoimmune hepatitis. We talked about some autoantibodies Andrew, what was the autoantibody that we had for an autoimmune hepatitis? It wasn't anti-Smith antigen. Anti-smooth muscle antibodies. So antibodies towards smooth muscle, that was positive. We also have a couple of others. LKM1 antibodies, soluble liver and kidney antibodies. So there are 3 subgroups at the top there that I put next to autoimmune hepatitis: anti-smooth muscle, LKM1 antibodies, soluble liver kidney antigen. The first and the last one present like classic autoimmune hepatitis in middle-aged people. The middle one tends to present in young women as in 15 to 25, very young women. Hemochromatosis, iron deficit, so that's just an autoimmune attack of the liver. If you're causing an attack of the liver for long enough, you're going to get fibrosis. If you get fibrosis, that is cirrhosis. If you get cirrhosis, it's not going to be able to perform its function. Bilirubin goes up, albumin goes down, INR eventually comes up. Estrogens aren't metabolized, vasoactive metabolites aren't metabolized, and then you're going to end up with all of your classical features of somebody with decompensated liver disease. And decompensation, somebody is decompensated when the synthetic function is abnormal and when they have ascites. Those are the things that you're looking for to say that this person has decompensated. Before then, if their synthetic function is working okay and their portal blood pressure is normal, meaning that they're not making ascites, at the moment, everything is still holding together. It's not functioning as good as it should, but it's holding together. Ascites equals decompensation. Synthetic function that was okay a couple of weeks ago or a couple of months ago and is abnormal now, decompensation. Hemochromatosis, old name of it was bronze diabetes, nice way to remember it. Skin pigmentation, pancreatic insufficiency. You get cardiomyopathy with it, and the easiest thing to get tripped up on it is the pituitary involvement. So infertility and also impotence associated with hemochromatosis. It is prevalent, probably about 100 times more prevalent than you realize that it is. It is a heterogeneous presentation, so people can be homozygotes, heterozygotes, and even the presentation of those can be spread out over a spectrum of disease. And lots of people that you have just assumed that they've got an alcoholic cause of their liver cirrhosis probably have an element of hemochromatosis as well. So a mild hemochromatosis may mean that somebody who drinks 50 units a week ends up with cirrhosis, whereas the next person might drink 90 units a week and be fine. It's probably an element of background hemochromatosis. So you deposit it in your pituitary gland, meaning the pituitary gland doesn't work as well as it should, and that's why you end up with impotence and hypogonadism, because it's primary hypogonadotrophic hypogonadism. That's what they tend to focus questions on. FSH and LH levels. If you had testicular failure, what would your LH and FSH levels be? Shamali, what would they be if my testicles failed? My FSH and LH be? They'll be high. It's just the same as any endocrine pathology. I'll be in a male menopause. Failure of gonads, increased in gonadotrophins. Wilson's disease, we've talked about that already, copper deposition, psychiatric, movement disorder. Hepatitis A and E, that is the two most likely to give you an acute hepatitic picture. B and C are most likely to be chronic. For purposes of your exam, hepatitis C can never present as an acute hepatitis C. You can present with decompensation of hepatitis C, but you don't get an acute hepatitis with it. Every now and again, you can get hepatitis B presenting as an acute hepatitis, and then it settles down and you're left with a background hepatitis B. That's why hepatitis C is such a nasty disease, because you don't seroconvert. In 80% of cases, you don't seroconvert, meaning you don't cure yourself. And then you don't even know that you've got the disease because you've never been unwell with it. It's just sitting along there in the background while you carry on passing it around to a number of other people. fluid. And this is fluid in pleural spaces and fluid in peritoneal spaces, meaning pleural effusions, and ascites. Causes of transudates and exudates are broadly the same when you look at the underlying pattern to their development. Exudates are the thick ones. Exudates are the thick ones are caused by malignancy, infection, and inflammation. So any malignancy that's got abdominal involvement can give you an ascites. Infection, less frequently, but sometimes in Crohn's disease. Same with inflammation from Crohn's disease. Inflammation from pancreatitis can give you an ascites. So a transudative ascites, and that is measured by your SAG. Your serum albumin acidic gradient, where you measure the amount of protein or the amount of albumin in your ascites and the amount of albumin in your blood, and you look for a difference between the two. And the greater that difference, the more likely it is to be a transudate, because you're squeezing water out of those tiny little pores. If it's the same, if the amount of albumin is the same in both your acidic fluid and also your serum, then it's just fluid that's leaking out of big holes that have been created by disruption of your membranes. Transudates. This is about protein, pressure, peculiar things. There's protein problems if I'm not making enough protein or I'm losing lots of proteins. So Rowie, can you give me a disease where you're losing shed loads of protein all of the time? Nephrotic syndrome. So nephrotic syndrome can give you a transudative ascites and a transudative pleural effusion. Malabsorption, where you're just not absorbing enough protein. Protein losing enteropathies, where the bowel itself is so damaged that it's just oozing lots of fluid that contains protein or not holding onto those proteins. And then liver failure, when the liver actually isn't able to make albumin and lots of other proteins. Pressure, this is about heart failure. High pressures, anything that's giving you a high portal pressure. And peculiar things. Hypothyroidism can give you transudative effusions. And this is where a bit of an argument can break out of Meague syndrome. Meague syndrome truly belongs in the exudative because it's caused by a growth within an ovary that is non-malignant that can give you an exudate, both a right-sided exudative pleural effusion and an ascites that is an exudate. And this is a tumor that's growing. It's a non-malignant tumor, but it's a tumor that's growing where the blood vessels are abnormal within it. But when you look at the case series, early on in the process, it's a transudate, and late on in the process, it's an exudate. So I don't know where it is that you would best put that. Should you put that on the exudate or should you put that on the transudate? So essentially, the questions that I've seen asked about this from the Royal College are usually which side is the pleural effusion. That's what they're alluding to. And there's a right-sided pleural effusion in Meague syndrome associated with an ovarian tumor, benign ovarian tumor, either on the left or the right ovary. And the ascites is actually tracked up into the pleural space, not the fact that you've ended up with an incidental pleural effusion at the same time as an ascites. So we're going to go for the question now. An overweight 58-year-old businessman with a history of type 2 diabetes consumes 42 units of alcohol per week. He presents to his GP, who examines the patient, and finds spider nevi, early clubbing, icteric sclerae, so you're talking about bilirubin that you can see now pigmenting the sclera. Usually notice with bilirubin levels greater than 50, less than 50 you can't really see it, and even around 50 it's quite difficult. Prominent veins around the umbilicus and a distended abdomen, which on percussion demonstrated shifting dullness. So this is saying the person has got ascites, which with the rest of the picture together is decompensated liver disease. What's the likely cause of this? Now you say alcohol, and that's a half reasonable thing to say, but if you ask most of the Caucasian population in England how much they're drinking, most of them are drinking about 35, 40 units of alcohol a week. So 42 units isn't really a lot of alcohol to be drinking. The other thing as well is the diabetes part. We're talking about somebody with liver failure. What are the other things? Non-alcoholic steatohepatitis, which we haven't brought into here, but also hemochromatosis in combination with alcohol. And as diabetes is from pancreatic insufficiency, and you can see how the hemochromatosis in combination with a moderate, a higher than advised alcohol intake can result in liver failure. So that's the reason that I've tried to introduce as many things as possible. Yes, it could be NASH, it could be. So non-alcoholic steatohepatitis associated with insulin insufficiency and being overweight. There's another name that's becoming vogue at the moment that won't have come in by the time you do your exam, so we'll abandon that for the moment. Blood results were as follows: ALT 320, ALP 144, which is raised. Is this a hepatitic or a cholestatic picture? Hepatitic. Bilirubin is 122, albumin is 24, and INR is 1.3. Is that INR raised? Yes, it is. So how far are we down the pathway of liver impairment, synthetic function impairment? Yeah, we're getting pretty far because we've got the bilirubin, now we've got the albumin, and then our INR is starting to come up. Gamma GT 211, so that's up. Just before we start answering this question, I'd like it to bring in gamma GT and its association with alcohol use. Gamma GT is most strongly associated with bile duct damage, but gamma GT can also go up with liver enzyme inducers. So anything that induces enzymes can bring this up. So this brings us up, do you know your enzyme inhibitors and enzyme inducer list? And again, you'll be hard-pressed to get away through your exam without there being a question about enzyme inhibition or enzyme suppression, induction and suppression. So let's quickly go through them. So PC bras and AO devices, I don't know whether you've seen these before. These are most of the anti-epileptics. So phenytoin, carbamazepine. B, people commonly get mixed up with this, barbiturates. Not benzodiazepines. Your brain wants to put them in there because you don't use these very much anymore, but they're still used for certain forms of epilepsy. Clobazam, clonazepam, these are barbiturates. Rifampicin. A. Alcohol. And S. Sulfonylurea, some people going sulfonamides. So we'll talk about this, how to remember this. Sulfonyl, put the sulf group there. A, O, 5 says. So A, amiodarone is one, allopurinol is another, so there are a couple. O, taking oral contraceptive pill. Not so much omeprazole. This is where the outbreak of publicity over clopidogrel and omeprazole came from. These are enzyme inhibitors. Now, if you give warfarin and you take an enzyme inhibitor, it inhibits the warfarin from being broken down, so it's active for much longer, so your INR goes up. So warfarin is more active. Many drugs are much more active when you prescribe somebody an inhibitor as well. Clopidogrel, though, is a prodrug. So clopidogrel has to be metabolized into its active form. And if you were prescribing omeprazole along with clopidogrel, the fear was that omeprazole would inhibit the enzymes that metabolize clopidogrel to its prodrug, from its prodrug to its active form. So this would stop the drug from being broken down into its active form. So that's where the outbreak. D, disulfiram. This is a drug that you don't really see anymore, but you use the term a disulfiram type reaction. This was an antibiotic many moons ago. When people took it and drank alcohol, they vomited like nobody's business. If you like watching old Columbo films, there's a Columbo film with disulfiram in it as well. And the thought was, let's stop using it as an antibiotic. We'll actually use it as an anti-alcohol medication, and it was called Antabuse. George Best, football player, was on Antabuse, and he used to boast about how much he could drink while he was still taking his disulfiram. E, erythromycin, the GP's drug of choice to kill their patients on warfarin. Numbers of patients I've seen with intracerebral bleeds or subdural hematomas, warfarin being started on erythromycin from their GP for a lower respiratory tract infection. So many. V, valproate. See, it's one of the only anti-epileptics that's on the inhibitor list. Most painful thing to happen in your exam, and I've seen it happen quite a few times, is you learn your PC bras and your AO devices, and then you can't remember which one's the inhibitor list and which one is the inducer list. The way I remember it in my head, bras seduce, induce. Seducers, inducers. I, isoniazid, isoniazide. C, rifampicin was on this one, anti-tuberculotic drug. Isoniazid. C, cimetidine, you don't really use it very much. E, ethanol, this is, which brings in, I see ethanol on this list, and I see alcohol on this list. Which is it? Well, if you are an alcoholic and you're drinking alcohol every single day, you're going to induce your enzymes. So that's why the first time you ever drink a bottle of beer will probably be enough to get you a little bit merry. And if you drink a beer every day, then that's a couple of beers, and then that's 4 or 5 beers in order to get you to the same merry state, because you're slowly inducing your enzymes in order to be able to metabolize. So chronic alcohol use is an inducer. Acute ethanol intoxication, that is an inhibitor. So this idea that somebody comes in, they don't drink usually, they've decided, I'm going to end it all, take a packet of paracetamol, take another packet of paracetamol, wash it down with a bottle of vodka, come into A&E, A&E say, it's taken with alcohol, that's an enzyme inducer, that puts the person into the high-risk category. They otherwise would have been okay, and we could have sent them home from A&E with review by the mental health team. But now that they've taken it with alcohol, they're in the high-risk group and they need to come in. It's actually even the opposite. They've actually protected them by taking drinking alcohol with it if they're not a chronic alcoholic, because they're inhibiting cytochrome P450 and stopping it from breaking paracetamol into its toxic NAP key, which bonds covalently to hepatocytes and causes damage. And this is sulfonal. This is sulfonamides. And the other one, sulfonyl, I gave it away a little bit, sulfonylureas. Most sulfonylureas, most commonly glycoside. Those are oral hypoglycemic drugs, drugs that when you take them can make you hypoglycemic. Metformin is not an oral hypoglycemic. You can take all the metformin in the world and you're not going to become hypoglycemic. It's an oral euglycemic. It's a part of my pedantic nature when it comes to the naming of drugs. Have you got that? So any of the drugs that are enzyme inducers can cause a rise in your gamma GT. So that's why alcohol has kind of become a little bit synonymous with gamma GT being up. But of all of the patients that you see, there's lots of people on lots of different drugs that could very well be enzyme inducers. So a gamma GT to decide whether somebody's an alcoholic or not really isn't a very good choice. So the question, which one of the following two statements is least accurate? Least accurate. This is characteristic of a hepatitic, not a cholestatic picture. We've said that that's true, so that's not our answer, because the ALT had gone up from 35 to 320. Acute hepatic failure, commonly occurring in hepatitis A and hepatitis E, rarely, if ever, occurs in hepatitis B and C. That's true. Hepatitis E plus pregnancy, badness. The mortality rate is incredibly high. So pregnancy, hepatitis E is bad, listeria is bad. AST to ALT ratio greater than 2 would be suggestive of an alcoholic cause. I put in your liver enzymes box down at the bottom. There are two things to take away from this, is that there is a rough association with an AST over an ALT being greater than 2 associated with an alcoholic cause. The next thing is alcoholic hepatitis very rarely gets your ALT greater than 200 and let's say 300. Very rarely does. From your clinical basis, got a minute, so 3 causes of why your ALT goes greater than 1,000. Only 3. Number 1, paracetamol overdose. 2, liver infarction. So this is ischemic liver. It can either be from an accident where you've disrupted the blood supply to the liver. It can be due to an hepatic vein thrombosis. It can be due to really severe heart disease that's resulted in cardiac pump failure. So pump failure, there's just not enough blood going around the body, and you might have seen people that have MIs, ALT, AST, all go up as well as their renal function tests go off, and they're unsavable frequently. So this is ischemia. 3, viral hepatitis. There's hepatitis A, hepatitis E, EBV as well. Surprisingly common EBV coming into hospital with abnormal liver function tests. If you get somebody with an ALT greater than 1,000 and you look for these and you can't find them, you haven't looked hard enough. You've got to go back and carry on looking. Time I remember in this hospital, actually, young girl who had come into hospital, can't remember what she had come into, but she ended up with an ALT that was 1,1400. And we went over it and over again and again, couldn't quite work out what was going on. And actually, she had had a lot of pain, abdominal pain, had been getting paracetamol, and she had also had cocodamol that a GP had prescribed her in her purse. And she kept on taking the cocodamol and the paracetamol that her nurse was giving, and it just accumulated over a period of days. And that's why she was just going back again and again, looking again and again until we finally got to the cause. So these are the only 3 real causes. So an AST over ALT ratio greater than 2 would be suggestive of an alcoholic cause. We've got at the bottom there on liver enzymes, AST over ALT is suggestive of an alcoholic cause. It's a weak association. High gamma GT is associated with bile duct damage and liver enzyme induction. True. That's not our answer. The higher the transaminase level, the more serious the liver disease. So this is in your brain. This tells you this sounds right. The reason that I put this in here is you've got lots of liver tissue. So rarely a little bit of damage to your liver will be enough to get your ALT, AST up quite high. If you've got liver cirrhosis, so all of your liver is fibrosed and you haven't got any hepatocytes left, how high is your ALT and your AST going to be? It might be moderately raised, it might not be raised at all, they might even be a little bit low. So you might have end-stage decompensated alcoholic liver disease, but you might still have a normal ALT and a normal AST. What will give it away that your liver's not working is the bilirubin will be high, the albumin will be low, and the INR will also be high. Bili high, INR high. So that's false. That's one of our answers. Constrictive pericarditis, as well as right heart failure, is a cause of cirrhosis and ascites. Yes, that's true. Constrictive pericarditis, not very common in England. Most commonly caused by tuberculosis. Very common in India, constrictive pericarditis, and you've actually got to do a pericardial ectomy. You've got to take the pericardium off the heart. So yeah, that's true. Constrictive pericarditis, right-sided heart failure, pulmonary hypertension, pulmonary stenosis, all of those can cause high pressures in the liver, cirrhosis, and eventually ascites. Hepatitis B surface antibodies present for greater than 6 months are indicative of chronic infection with hepatitis B. False. It's trying to suck you into the antibody-antigen thing. So we've got our 2 answers, but we'll do the last one. Endoscopic banding should be chosen in preference to sclerotherapy in acute variceal bleeds. That's true. Sclerotherapy has no real role in any exam question or in any real discussion. It might be tried out of desperation, but it's not part of the structure for treatment of variceal hemorrhage anymore. It was. Any questions?